Hello, everyone. Today you have a very common case that we face every day in our practice, a case of volume overload with heart and kidney problems. He is a 56-year-old man who was admitted to the hospital with worsening dyspnea and 8 kilogram weight gain. He has history of congestive heart failure, and now he has acute decompensated heart failure. He has long history of type 2 diabetes, hypertension, coronary artery disease, CKD stage 3B, ischemic cardiomyopathy with ejection fraction 30%. Is adherent to his medication, including losartan, furosemide 40 milligram twice daily, atorvastatin, and insulin. His blood sugar is well controlled. However, his blood pressure is 162 over 92, heart rate 104. Physical examination showed S3 gallop, bilateral crackles, plus 3 pedal edema. Lab showed serum sodium of 132, potassium 5.2, BUN 63, serum creatinine 2.1 from a baseline of 1.4. And the question is, what is the following um, statement is best choice next step in this patient management? So this patient with acute decompensated heart failure, CKD, diabetes, hypertension, was admitted to the hospital with volume overload. Would you start him on furosemide IV infusion, or start metolazone, or start dapagliflozin, or initiate isolated ultrafiltration, or discontinue losartan? Then after 2 days of the hospital stay and proper management, the patient start to lose fluid. Blood pressure is better controlled. He's making 2.4 liters of urine. His creatinine improved from 2.1 to around his baseline. And now you are preparing him for discharge, and the team is asking you about the diuretic management that you would like to send the patient on, and the patient has appointment with his primary care physician in a week. And the question is, which of the following is the most appropriate diuretic regimen to discharge this patient on? Would you like to switch his IV furosemide infusion to oral and give him 120 milligram twice daily of furosemide plus 10 milligram of metolazone? Or would you like to keep him on 80 milligram of furosemide twice daily, or 160 just daily, or Biomix 4 milligram twice daily, or Biomix 4 milligram daily? And the right answer for the first question is, once you get this patient admitted to the hospital with volume overload, it's better to start him on IV loop diuretic infusion. And when you are planning to discharge him, I think the best medicine and the dose you need to put him on is furosemide 80 milligram twice, and I'm going to show you why. Volume overload is defined as excess total body sodium, not only water, but also sodium. So both sodium and water with expansion of the extracellular fluid volume. Volume overload is very challenging in patients with chronic kidney disease, congestive heart failure, cirrhosis, and portal hypertension, and of course, patients with nephrotic syndrome, because these patients with nephrotic syndrome, they are hypoalbuminemic, they could be intravascular volume depleted, but the interstitial fluid is overload. So it's challenging, and a specific pathophysiology of these diseases varies, but most patients present with one or more of signs of volume overload, like increased blood pressure, peripheral edema, pulmonary congestion, hypoxia, and ascites, and of course, leg edema. Here is the causes for diuretic resistance, and it's very common that the patient would be non-adherent to either to the salt intake or to his medication. So please review the salt intake with the patient. If you're not sure, do 24-hour urine sodium. If it is more than 120, this means that the patient is not compliant with salt, is adding a lot of salt in food. Non-adherence to medication is a major challenge, so you have to encourage the patient and counsel him and to have strategies to improve his compliance. Of course, make sure that this is a real volume overload because in several circumstances, it could be pseudo hypervolemia because of lymphedema or venous stasis. And this patient, when you overdiurese them, they end up by having acute kidney injury. Here are the rest of the causes, but I'm just emphasize again on the hypoalbuminemia and the portal hypertension because this can induce gut edema and failure of absorption of the available diuretics. So again, back to our patient. This patient presents with acute decompensated heart failure associated with resistance to oral furosemide. The best next step in management is to change furosemide from oral to IV because with the gut edema the patient have, he cannot absorb the oral furosemide. So changing this because the bioavailability of the furosemide is low, it's about 50%. Additionally, most contemporary guidelines suggest using 2 to 2.5 times of the home dose. So he was on 40 milligram twice, so you need at least to double this. So you go up to 80 to 100 milligram of IV Lasix. And furosemide could be changed also to Biomix or torozumide, and I'm going to show you the equivalent doses. So make sure that metolazone could be added also to block the distal convoluted tubule sodium reabsorption in conjunction, but not in replacement of the loop diuretic. Loop diuretic is stronger. Dapagliflozin improves the outcome in congestive heart failure and CKD patient, but it cannot replace IV loop diuretics. Isolated UF, of course, removes the fluid more efficiently and quickly. However, it's associated with adverse events and more cost, but it decreases the hospital stay. It's not associated with improvement of any of the renal outcomes or patient survival, but it shortens the hospital stay. Stopping losartan is a common mistake because of mild hyperkalemia or increase in serum creatinine, because losartan actually is helpful to decrease the afterload of the heart and to improve the cardiorenal syndrome and to improve renal perfusion. So, and adding also loop diuretic would help with the hyperkalemia and with the volume overload. So try not to stop losartan except if the patient really have significant, decrease in the GFR or hypotension or intractable hyperkalemia. Furosemide 80 milligram IV followed by infusion of 5 milligram per hour. This was our first choice for this patient. So you give him bolus dose because you need to, increase the furosemide, level in the blood quickly. So you give bolus of 80 milligram, then you put him on 5 milligram per hour. So a total of 120, in that 24 hours, you do the math. The patient responded well. His urine output was more than 2 liters. And after 2 days, his dyspnea and the peripheral edema improved. His weight gain improved, and his blood pressure is well controlled. And his creatinine actually improved because in this kind of cardiorenal syndrome, when you diurese them, actually their heart function improves, their kidney perfusion improves, and the creatinine goes down. Preparing this patient for discharge is very important issue and a challenge here. So we need to know how we convert the IV to oral diuretics. So we elected to put the patient on 80 milligram twice daily of furosemide as a home dose. You remember he was on 40 milligram twice daily when he got admitted to the hospital with volume overload. Now we doubled the dose to 80 milligram, and I'll show you why. The pharmacokinetics describe how the drug is absorbed, distributed, metabolized, and eliminated by the body. For example, furosemide is absorbed similarly in the stomach and duodenum, although gastric absorption is slow and include first bypass metabolism. So this effect may account for the lower bioavailability, about only 50% of the oral furosemide is bioavailable, while the biomix and torezomide, they have more than 80% bioavailability with the oral forms. So it doesn't make difference with the biomix and torezomide if you give it oral or IV because better bioavailability, while in cases of furosemide, you need to double the dose. So such a difference in bioavailability have an implication for IV to oral doses, and generally furosemide should be the dose should be doubled when making this change, but biomix and torezomide it can stay the same because the equivalent dose of oral and IV are almost the same. We have to remember that furosemide is one of the few medications that is completely metabolized by the kidney, while torezomide is metabolized mainly by the liver. Triametrine is inactive; it needs hepatic activation. So, in patients with chronic liver disease or end-stage liver disease, it cannot work; it cannot be activated. Peak serum concentration of loop diuretic occur within about half an hour to 2 hours, or almost 1 hour, even though the drug effect may last for about 6 to 8 hours, especially with impaired kidney, liver, or heart function. The short elimination half-life of the most of loop diuretic, except torezomide, which is longer acting, mean that it's typically need to be given twice daily, not once daily, because if you give it once daily, you will have, about 12 hours that is associated with unnecessarily increase in sodium concentration and the sodium retention that induce fluid retention. There is no need to give it 3 times a day because at night there is zero sodium intake, so it doesn't really need to be thrice daily medication, but twice daily should be fine. If loop diuretics are prescribed only once daily, the kidneys are diuretic free for many hours, allowing considerable rebound sodium reabsorption and retention in these cases. Thiazide diuretics are longer acting, especially chlorthalidone, actually is longer acting than hydrochlorothiazide. So this patient was initially prescribed furosemide loading dose 80 milligram IV in the hospital, and then both on 5 milligram per hour of Lasix IV infusion. So he received 80 plus 120 to about 200 milligram during the first and another 120 milligram in the second day. So this day is equivalent to 280 milligram a day orally, which should be given 120 milligram twice daily to avoid post-diuretic sodium reabsorption. However, if the patient already responded very well and the signs of volume overload is improved and he is making good urine output, you don't really need to send him home on this dose of 120 milligram twice a day, and it's enough to give him 80 milligram twice a day. And here is my last but very important slide. This is the pharmacokinetics of various diuretics. You need to remember that in the loop diuretics, furosemide, the bioavailability is low, about 50%, while biomix and torezomide is almost 100%. So oral to IV doubled, and here oral is equal to IV because there is no change in bioavailability. And also here with the furosemide, gut edema actually interfere with the absorption. So that's significant. Either you need to give higher doses or you need to switch to biomix or torezomide or switch oral to IV furosemide. Again, thiazide diuretics, we have hydrochlorothiazide and the longer-acting chlorthalidone and metolazone, and the bioavailability of these drugs ranging between 60 to 70. The metolazone has better bioavailability. Then we have the amiloride, triametrine, and spironolactone. Spironolactone has much better bioavailability compared to amiloride and triametrine. It's important to know the equivalent doses. So 1 milligram of Biomix equal to 20 milligram of terizumide equal to 40 milligram of uh, oral furosemide. Hydrochlorothiazide 25 milligram equal to 12.5 milligram of chlorthalidone and 2.5 milligram of metolazone. 10 milligram of amiloride is equal to 100 milligram of triametrine and 25 milligram of spironolactone. The metabolism is important because many of our patients have either kidney impairment or liver impairment. So we have to understand that furosemide is 100% metabolized in the kidney, while Biomix and furosemide are metabolized by both kidney and the liver. Biomix is 50-50 and furosemide is 80% metabolized in the liver. Thiazide diuretics also are mainly metabolized in the kidney. Okay, so we don't have many medications that are metabolized in the kidney, but among of those we have the furosemide and we have hydrochlorothiazide and chlorthalidone and also metolazone. These drugs are mainly metabolized in the kidney. The amiloride, triamethylene, and spironolactone, mainly amiloride is metabolized by the kidney, 50%. The rest are metabolized mainly by the liver, the triamethylene and spironolactone. And here is the half-life. The shortest half-life is the Biomix starts, the half-life is 1 hour. For the Lasix, it's 1.5 hour to 2 hours. For the terazomide, which is longer acting, 3 to 4 hours. Of course, this is going to change in patients with kidney disease, heart disease, or liver disease. Thiazide diuretics actually have longer half-life, especially chlorthalidone that cover for the whole day, 40 to 60 hours. Hydrochlorothiazide should be given twice because it's, after 12 hours, its level in the serum goes down. Metolazone is usually also BID. It can be given also once daily, but chlorthalidone is much long-acting, thiazide diuretic. Amiloride, trimetrine, and spironolactone. The amiloride is, varies from 6 hours to 26 hours. Trimetrine is short-acting, 2 to 5 hours, and spironolactone is very long-acting, more than 15 hours. Here is my suggestion for you. This American Journal of Kidney Disease core curriculum in nephrology, diuretics in states of volume overload core curriculum that was published 2022. Very nice article, and it has cases, so it's very educational article. So I really encourage you to read it. And again, thank you so much, and hopefully this will help you in your practice, because knowledge is of no value unless you put it in practice. And the great aim for education is not knowledge, but action. Thank you, and have a good rest of your day.